Hi everyone, I'm Dr. Roman and I'm a hematologist oncologist, and today we are going to go over chronic lymphocytic leukemia, also known as CLL for short. Now I must tell you, as with all my videos, I'm going to try to keep it as simple as possible, yet provide all that crucial and important information that you need to know exactly what is CLL, what is going on, and what questions to ask when you go see your doctor. This video is valid, for example, if you're a patient, a family member, maybe a medical student, maybe even a primary care physician that wants to learn about CLL. But I must warn you, there's a lot of information to cover, and at times you may feel somewhat discouraged. But I promise you that if you watch it, I will tie everything in at the end. There are going to be some slides where you're going to feel a little bit lost, and then the next slide, it ties in. And I promise you, you will have that aha moment when you finally start to understand what is going on in CLL. So with that being said, let's get started. And always remember, my videos are for educational purposes. All right, so starting off with a brief overview of everything we are going to cover. We're going to go over the clinical presentation and just basic facts about CLL, symptoms that you may have, how do we make the diagnosis of CLL, the staging, treatment options, and how do we monitor patients with CLL. Believe me, everything that you need to know, we are going to cover, and we're going to do so in a simple way because I want you to understand what's going on. You know, us doctors, a lot of times we use complicated terminology and it just throws people off. I'm going to try to avoid that, okay? Keeping it simple, yet providing all that crucial information. Notice I put on here questions, and what I mean by this, I have a slide in the middle of the presentation where I wrote down all the important questions that I would have if I had CLL. And I want to remind you, I am a cancer doctor. I treat patients with CLL. And these are the questions that I would have if I was a patient. So I recommend you find yourself a piece of paper and a pen and write some of these questions down because these are the questions you want to know and you want to ask your doctor. I also recommend that you find whatever blood tests or any testing that you've had done because we're going to cover a lot of this and you can follow along with me and you can actually look at your results and know exactly what's going on, all right? So let's go to the next slide. All right, so let's start off with some basic details about CLL. First of all, it is the most common form of leukemia, period. I see this leukemia all the time. The other thing that I want you to keep in mind is when I see patients with this for the first time and I tell them that they have leukemia, they panic. You can tell in their face that when that word leukemia comes out, their stress level shoots off the roof. And the important thing here is that you need to keep in mind that this is a chronic leukemia. There are many different types of leukemia. Acute leukemias are very aggressive, whereas chronic leukemias take a long time to grow. They're much slower growing, and that's important because this leukemia is not as aggressive as other forms of leukemia. Okay, so that's the first thing that I want you to keep in mind. The next thing is that it is more common in men than women. The average age is around 70 years of age, although there are patients less than 55 years of age with this form of leukemia, but usually that is seen in less than 10% of cases, okay? That's why a lot of times the way that I remember it, CLL, LL for later in life, it's just a little way that I remember versus other forms of leukemia. Now, I put on here variable presentation, and notice that I put most are asymptomatic. What I mean by this is that most patients with CLL have no symptoms. They feel great, they go to their doctor, they have a routine blood test done, and the doctor calls them and tells them, you know what? We have a problem, your white blood cell count is very high. That's usually the way it's detected, okay? Although some patients may have symptoms, and we're gonna go over this. But for the most part, most patients have no idea, and they're told, you know what, your white count is high, you gotta go see a hematologist. So I'm sure a lot of you watching, that's exactly what happened, okay? So no, you're not alone, very common presentation. So usually found with an elevated white blood cell count on a routine CBC. Very common. Now notice I put here indolent to more aggressive. And what I mean by this,
When we touch here, maybe just try this, ladies and gentlemen.
CLL, for the most part, is a very slow growing leukemia. Now, some patients have CLL that is extremely slow growing. And then there are other patients with CLL that the CLL is a little bit more aggressive. And we are going to go over why this is. Okay, so think about it. It's wonderful to know that we have tests available that are good predictors as to how aggressive or non-aggressive your CLL will be. And I promise you we're going to go over this and we're going to tie it all in, okay? Now, the clinical presentation, as I stated, most patients come in with a blood count, their white blood cell count was elevated, and that sparks the whole workup. Now, some patients can have symptoms, although it's the minority. One of the more common symptoms or findings that I see are lymphadenopathy. These are swollen lymph nodes. We have lymph nodes all over the body, for example, our neck, under our armpits, in our inguinal area, and a lot of times people with CLL, if you examine them, you can feel these lymph nodes. And the reason is that a lot of patients with CLL also have SLL, and this stands for small lymphocytic lymphoma. That's right, a leukemia and a lymphoma. But don't panic, it's the same thing. When these CLL cells are in your blood, it's called CLL. You have a leukemia, chronic leukemia. When they are in a lymph node, it's a lymphoma, but it's the same cell. We treat them the same way. And a lot of times I'll actually put CLL/SLL because it really doesn't matter. Most patients, or a lot of patients with CLL, have SLL, and no biggie, we treat it the same, okay? So I just want you to know that. So one of the things that you may feel in your body if you examine yourselves are some of these lymph nodes, okay? And a lot of times they're very small, but you can actually feel them. Now, some patients do not have these lymph nodes, so if you don't have them, great. Another thing that patients may have is what we call splenomegaly. Their spleen may become large, okay? And the spleen may become big enough that it compresses the stomach and it can cause symptoms. So that's another thing we find. And the last type of symptoms that we find are what we call B symptoms, okay? B as in boy. And these symptoms are three, and that is fever, a lot of weight loss, and drenching night sweats. And I have to tell you, the fever comes and goes, and you have no idea why you have this fever. The other thing is significant weight loss. It's usually about greater than 10% of your body weight over a 6-month period. And the last one is drenching night sweats. And I tell patients, because most of us sweat when we sleep. But no, it's not regular, typical, just light sweating. No, as the name says, drenching night sweats. And a lot of patients will tell me, Doc, I wake up and my clothes, I have to take them off and change my clothing because I'm drenched in sweat. And those are called B symptoms. And if you have that, you have to let your doctor know, right? So let's move on. So continuing with symptoms, fatigue, very common. And a lot of times, if you have more advanced CLL, the fatigue can be severe. As I stated, the elevated white blood cell count, usually your lymphocytes, and we're going to go over that because I have a CBC that I'm going to show you. The lymphadenopathy that I told you about, the swollen lymph nodes, the easy bruising you may also see, as well as fullness when you eat. Remember, that spleen may be pushing on your stomach and your stomach cannot dilate, okay? As you eat, the stomach is being pushed upon by the spleen and you eat very little food and you have early satiety, okay? So a lot of these I'm repeating because we learn through repetition. So believe me, when you watch this video, you're going to hear it a few times and you're going to know what I'm talking about. And remember the B symptoms that we went over already, which are the fever, the unexplained weight loss, and the drenching night sweats. So how do we make the diagnosis? And I can tell you, with experience, I've seen so many patients that I can look at a CBC, I can speak to a patient and examine the patient, and I have a pretty good idea what's going on, that this patient has a high likelihood of having CLL. But how do we confirm this diagnosis? Well, first of all, as I said, we look at the complete blood cell count, and I have one to show you coming up. So we look at that, and we're going to notice that your white blood cell count is high. Specifically, when we look down, your lymphocytes, which is a type of white blood cell count, is the one that's predominantly elevated. And I'm going to show you this. I'm going to give you an example. The other test is what we call a peripheral blood flow cytometry. That's a simple blood test which will tell you if they find CLL or no. In other words, it detects clonality, clonal cells in your blood. Okay, so if you've had a flow cytometry, find it and read it, and it should say highly likely of CLL or a clonal B cell population detected. You know, there's a lot of ways we put it, but it'll tell you CLL is most likely. Very easy. The other test that we do is what we call a CLL FISH panel, and we're going to go over this. This is just looking for genetic abnormalities, very simple. Another test we do is IGHV gene status. Very important, and we're going to go over this because all of these tell us, remember I told you, to predict if your CLL is going to be aggressive or non-aggressive. Well, these are the tests that we use, and I'm going to go over all of these. Another test is a simple blood test, beta-2 microglobulin. Another simple blood test is an LDH level. And the last blood test is a CpG karyotype testing. This is simply, we want to study your chromosomes. It's a karyotype, okay? And we're trying to see, are your chromosomes normal, or do you have chromosomal abnormalities that you've acquired because of your age? Remember, the older you become, the higher the chances that you have developed genetic damage. In other words, damage to your DNA. And this can cause the CLL, and that's what we're looking for with a lot of these tests, okay? Now, imaging tests. CT scans are sometimes used because remember, we want to find those lymph nodes, okay? A lot of times we may not perform a CT scan, but if you have a lot of lymph nodes, we may consider performing a CT scan. And last but not least, a bone marrow biopsy. Now, a lot of times we do not need to perform a bone marrow biopsy, but there are times that your doctor may recommend a bone marrow biopsy. One reason is maybe they think you have a lot of leukemia in your bone marrow, and if you perform a bone marrow biopsy, you can actually quantify how much leukemia burden or how much disease you have in the bone marrow. Another reason would be, let's say that your blood counts are low, you have a lot of anemia, maybe your platelets are low, and your doctor has a feeling that maybe it's not due to your CLL. So they may want to exclude another diagnosis. Just as an example, there's an entity that's called a myelodysplastic syndrome in which your bone marrow doesn't work normally. So maybe your doctor wants to say, you know what? I want to make sure this patient does not have a myelodysplastic syndrome. So just giving you an example. So sometimes your doctor may recommend a bone marrow biopsy, but most of the times I would say that it is not necessary, okay? All right, now your CBC. I'm sure you have had a CBC, so I recommend you find your CBC, which is your complete blood cell count, and you follow along with me. So first of all, I'm going to go over what's normal, and then we will get into the CLL findings on a CBC. So first of all, when you look at a CBC, there are three things that I want you to look at. I want you to look at the white blood cell count, the hemoglobin, and your platelets, okay? Now, your normal white blood cell count is 3.4 to 10.8. It varies, so anywhere between about 4 to 10. That's usually normal level. Hemoglobin, usually around 13, maybe 12 something in a woman, around 13, 14 in a man. And your platelet count is usually around 140 to 450. Those are the normal ranges. Okay, so if the other thing that I want you to look at is what we call the differential. Okay, if you look down, I want you to notice here that you have your neutrophils, lymphocytes, monocytes, eosinophils, and basophils. These are all types of white blood cells. And if you add all of these white blood cells together, this gives you the total white blood cell count at the top, okay? Now, there's two ways. When you look at your CBC, I want you to notice that it says, and if you follow along in the picture, neutrophils, lymphocytes, monocytes, eosinophils, basophils, and then it goes over, again, neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And why are they going over them two times? Well, if you notice, on the top here, it's just in a percentage, whereas on the bottom here, it's an absolute number. So the way that we calculate or we figure out your total white blood cell count, notice in this example, this patient's white blood cell count is 52.9. Well, if you go down, Their neutrophils are 2.2, that's 2.2 thousand. Their lymphocytes are 50.2 thousand, and then their monocytes are 0.4, eosinophils are 0.1, and if you add all of these up, if you add this total number up, that will equal 52.9, okay? So it's an absolute number that we look at. So now, this patient has CLL. So let's see what we find in a patient with CLL. And every patient's different, but I want to show you an example. So notice the first thing that pops up here is this very high white blood cell count. It's 52.9, that's 52,000. Pretty high platelet count, white blood cell count. Then you look at the hemoglobin level. This patient has a little bit of anemia. It's 12, okay? That's another thing we want to look at. And the platelet count is normal at 164. And if you go down and you look at the differential, remember CLL, chronic lymphocytic leukemia, lymphocytic for lymphocyte. And there you go, your absolute lymphocyte count is the one that is very elevated. So when you see this, you tell yourself, you know, as a hematologist, I look at this, okay, the white count is high. I go down, I look at the differential, and I notice, the elevated white blood cell count is almost all lymphocytes. So right there, that's the first thing that I look at, and it tells me, you know what? Chances are we're dealing with a CLL. Another thing that we very often find, notice here how it says smudge cells present and atypical lymphocytes present. Very common in patients with CLL. So when they perform the blood test, okay, when they do this, they can do a peripheral smear and look at the blood under the microscope. And when they prepare these slides for looking at under the microscope, these CLL cells are very frail. They're very fragile. And they can smudge, they can break. And it looks like if you smudged a lymphocyte on the smear. That's why we call them smudge cells. You know, it's not specific to CLL, but very common in CLL. And atypical lymphocytes, because again, your lymphocytes are very high, but since this is a chronic leukemia, they're not perfectly normal lymphocytes. So when you look at them under a microscope, they don't look typical. They look atypical, meaning abnormal. And that's where the atypical lymphocytes comes from, okay? So again, just as a quick recap, find your CBC, your white blood cell count, chances are it's going to be elevated. You want to look at your hemoglobin, see how, if it's normal or if you have anemia. Do you have low platelets or are your platelets low? Important, and we're going to go over why. And then go down and look at the differential, okay? And you're going to notice that your lymphocytes are the ones that are going to be elevated. Now, the last thing that I want you to keep in mind, sometimes your white blood cell count is very mildly elevated, okay? Very little. And when you go down and you look at the differential, your lymphocytes are a little bit elevated. And the important thing here is, if your lymphocytes are less than 5,000, then maybe you do not have CLL. You might have something that's called monoclonal B-cell lymphocytosis. Because in order for it to be CLL, your lymphocytes have to be greater than 5,000. And this patient is easy. This patient has 50,000. So obviously very high. But if the lymphocytes are less than 5,000, maybe you do not have CLL, and that is something that you need to talk to your doctor about. And that's important because a lot of patients with this may never develop CLL. So you don't want to be labeled as having CLL if you don't truly have it. And I'm going to give you another example coming up.
יש לכם גולד בארנק. גולד עם חברות לשנתיים.
All right, so you saw your CBC, your white blood cell count is high. You notice that it's almost all lymphocytes. You know, it looks like a CLL. So how do we confirm it? All right, here we go. Remember, we went over the peripheral blood flow cytometry. This is a blood test that you're looking, and it's going to tell you if you have CLL or not. So it's going to tell you, yes, you have CLL, or no, there is no CLL. Very easy. If your lymphocytes are greater than 5,000, then it's CLL. If your lymphocytes, remember, you already know what I mean by that because we went over it on the CBC. If your lymphocytes on your CBC are less than 5,000, then it's a monoclonal B-cell lymphocytosis. But you cannot have symptoms. If you have lymph nodes, or if you have B symptoms, if you have a very large spleen, then we can say, you know what, even though the lymphocytes are less than 5,000, the patient has symptoms, okay? And in those cases, we'll say, you know what, we're gonna call it CLL anyway. So if your lymphocytes, once again, your lymphocytes are less than 5,000 and you have no symptoms, it's called monoclonal B-cell lymphocytosis. And the important thing is 1 to 2% risk per year of developing CLL. So think about that. You know, there's a good chance you may not develop CLL. All right? Remember we went over the beta-2 microglobulin, very easy, cheap blood test that your doctor can do. So little blood test, and if it's normal, that is good. If it's elevated, it implies that your CLL may be a little bit more aggressive. That's all that means, okay? It's not a 100% reliable test. These just give us an idea. Another test is an LDH, which stands for lactate dehydrogenase. Once again, if it's very high, it suggests that the CLL is a little more aggressive. If it's normal, it suggests that the CLL is a little more indolent, okay, or slow growing. Again, not a perfect test. These just give us an idea. All right, the next test, and I need you awake because this is very important, okay, is what we call a CLL FISH panel, or FISH testing for CLL. It stands for fluorescent in situ hybridization. It's a simple blood test, and what we are trying to find here are chromosomal abnormalities, okay? Remember, every cancer develops because of DNA damage or mutations. Well, we want to know, do you have mutations that we can find, okay? There's a reason for that, and we're going to go over that. So, for example, if we do a CLL FISH panel, and if you've had this test, find it and follow along with me. If you've had a CLL FISH panel and we find that you have a deletion 13q, okay? So that arm of the 13th chromosome, of chromosome 13, is deleted, that's good. Most patients that have this, their leukemia grows a lot more slowly. It's more of an indolent CLL. If you have a trisomy 12, that's intermediate, that's so-so. If you have a deletion 11q, that's not good. And if you have a deletion 17p or a TP53 mutation, that is not good. That tells us that your leukemia, your CLL, is likely to behave more aggressively. And we want to know that for many reasons, obviously. And the last one here is it can also find a translocation 1114. Just know that if you have this translocation, they need to exclude, or they need to rule out another entity that's called mantle cell lymphoma. So, you know, I don't really think you need to know this, but I'm just telling you so that you know, how do we decide, or how do we know if your CLL is going to behave less aggressively or more aggressively. So as a recap, this is what you need to know. We can do a CLL FISH test to find, you know, if you have one of these chromosomal abnormalities, and if you do, it's predictive, like I said. Some of them, like 13q, is good, whereas others, like an 11q or a 17p or a TP53, are bad. Now, what if you have a CLL FISH panel and it's normal? It doesn't find anything. Well, you know what? That's intermediate, okay? Because some of them are good, some of them are bad, and some of them are kind of in the middle. If we don't find anything on this test, then it's not a good thing and it's not a bad thing. It's intermediate, okay? Just thought you needed to know that. Another blood test that we can do is what we call immunoglobulin heavy chain variable region testing, okay? IGHV for short. And it's very simple. It's either going to tell you your CLL is mutated, this is mutated, or it's not mutated. And if your IGHV is mutated, that is good. If it's not mutated, it's not as good. That's all you need to know. So ask your doctor if you've been tested, mutated, or not mutated, okay? The other test here is CpG karyotype testing. And if you remember from college or your high school days, karyotyping are your chromosomes. Once again, it's another method that we're looking for chromosomal abnormalities. And again, if we find some of these chromosomal abnormalities may be bad. So we want to know if you have some other type of chromosomal abnormalities. And the other thing is, if you have multiple chromosomal abnormalities, some patients may have 3, 4, 5, 6. I mean, everybody's different. If you have many chromosomal abnormalities, we call that a complex karyotype. Complex because it's complicated. There's a lot of mutations there, and that's not a good thing. So remember at the beginning where we said we would like to predict, because a lot of patients with CLL, it can behave aggressively or indolent. Well, this is how we determine that, okay? We put all these tests together and we can predict, you know what, chances are a long time will go by before this patient may even require treatment, okay? And that's very important to know. Now, I'm going to give you an example. My father was diagnosed with CLL when he was in his very early 70s, okay? He came to me with a high white blood cell count. I did the testing, and lo and behold, he had CLL. Now, I did all these tests, and some of these were available, others were not, because this was a pretty long time ago. But he had a chromosome 13Q, so he had a 13Q deletion, and he had an IGHV mutation. He had those two things. Remember, those two are good. So 13Q is good, and if you're mutated, IGHV, that's also good. Well, I'll tell you what happened to my dad. He lived for about 15 more years, never required treatment, although he was worried because, you know what? Oh my God, I have leukemia. And I used to tell him, Dad, listen, you have these good findings, these good risk findings. Chances are you're not going to die of your CLL. Well, my father lived to be 85 years old, and he passed away last year of dementia. Alzheimer's type dementia. So there you go. You know, he lived about 15 years with CLL and died of something else, which is extremely common with CLL. So if there's one thing you can take home from this video, is that most patients with CLL die with CLL, not because of CLL. In other words, they die of something else, not because of their CLL, okay? So I need you to know that, so maybe that brings a little bit of peace of mind to you, okay? Let's move on. What about CAT scans? Well, sometimes we perform, as I stated before, we're looking for the lymph nodes. Sometimes it's done, especially if a person has a lot of lymph nodes. And again, you know, if you do have a lot of lymph nodes, it's more commonly what we already went over, SLL, small lymphocytic lymphoma, which is the same thing as CLL, okay? Same disease, we treat it the same, no big deal. And as I mentioned, we already went over the bone marrow biopsy. It's usually not needed, but we can use it to find other causes of cytopenias, meaning other causes of anemia or low platelets, etc.
The Japanese mosquito device that's...
All right, here you go, the money slide. This is the slide that you need to know, okay? These are the questions that I would have up to this point. Question number 1, what does your CBC show? How high is your white blood cell count? What about your lymphocytes? Are they greater than 5,000? Remember? Is your hemoglobin normal, or do you have anemia? Is your platelet count normal, or do you have thrombocytopenia, meaning your platelets are low? And you need to know all this. Question number 2, do you have symptoms? Are you losing weight? Do you have fever? Do you have drenching night sweats? You know, do you have early satiety? You eat and you become full right away. Do you have that disabling fatigue? These are all questions that you need to know. So yes, you have symptoms, or no. And remember, you need to try to decipher normal symptoms, because I'm 50 years old at this moment, and I get home after a long day's work, and I'm tired. I have fatigue. So remember, you have to kind of, know, is this normal fatigue expected for whatever your daily routine is and your age, or is this a different type of fatigue? It's just disabling fatigue, which you cannot attribute it to your activities of daily living. Okay, it's very important that you try to determine that. The flow cytometry results. What was your peripheral blood flow cytometry result? Remember, that'll tell you yes, there's CLL, or no, there's no CLL. What about your CLL fish? Remember, you want to know, is this aggressive, or is this going to behave not as aggressive? So do you have a 13Q, a trisomy 12, 11Q, a 17P? You guys, you got to know this. So ask your doctor if they did CLL fish testing, what are the results? What was your beta 2 microglobulin, the simple blood test? Was your LDH normal or elevated? What about IGHV mutation testing? Did they do it? If it's mutated, that's good. If it's not mutated, that's not as good. What about your karyotype? Remember, your chromosomes. Do you have other chromosomal abnormalities? Yes or no? Okay, and if you do, is that a good thing or a bad thing? Which chromosomal abnormality was found? So the last question here, do you have high risk or lower risk CLL? And to know that, you have to know all of the above, or most of the above. You know, there are some times where a doctor will perform most of these. Sometimes we do not perform all of them. Just keep in mind that, you know, these are all tests that your doctor can perform. So those are the questions that I would want answered. So a little favor, if you're liking this video, if it's helping you, like. So let's briefly go over staging. How do we stage CLL? Well, it's stage 0, stage 1, stage 2, stage 3, and stage 4. So stage 0 simply means that the only thing we find is an elevated white blood cell count, specifically your lymphocytes. Stage 1 is that you have CLL and also lymph nodes, okay? Stage 2 is CLL and your spleen is large. Stage 3 is the lymphocytosis. You know, you have CLL and you also have anemia. Now, the important thing here is you want to make sure that you don't have anemia because of something else. For example, you may have CLL, and if you have iron deficiency, you will also have anemia. So make sure your doctor excludes other reasons for the anemia. Very important. And last but not least, stage 4 is that you have CLL and your platelet count is low. And again, you want to make sure they exclude other causes of low platelets. Very important, okay? I always make emphasis on this because you can have a patient that can have, you know, CLL and maybe has another reason which is the cause of his or her low platelet count. And just know that in general, the higher the stage, the more advanced your CLL tends to be, okay? That's all that means. Now, treatment. Very important. I hope you're awake. I know this is not very exciting, but guys, you need to know this. If you have CLL, you need to know this. If you're a nurse, a medical student, or a doctor, you need to know this in order to treat patients. So believe me, I know it's boring, but you need to know it, all right? So the treatment. Question number 1, do you need treatment? I already gave you the example of my father. Most patients with CLL do not require treatment, or a lot of patients do not require treatment. You can follow them. It's what we call wait and watch, or watch and wait. And if a reason pops up in the future, we treat it if we have to. So the first question is, do you need treatment? Very important. I know if I don't need it, I don't want to be treated if I had CLL. So, you know, again, do you need treatment? So there's no evidence suggesting that early treatment prolongs survival. I want you to think about that. There is no evidence that treating CLL early will prolong your survival, period. So again, treat it if you have to. And we're going to go over the reasons as to why we would treat your CLL. The first thing is, if you have symptoms of CLL, then that is a reason to treat. So let's go over this. So for example, if you have the dreaded B symptoms that we already went over, you're having fever, you're having the weight loss, you're having the drenching night sweats, we would treat you. If you have severe fatigue that we cannot attribute to something else, so in other words, the CLL is likely causing this severe fatigue, we would consider treatment. Also, if you have very large lymph nodes, especially if they're bothering you. I mean, if you have a big lymph node in your neck or a big lymph node under your armpit and it's bothering you, I mean, it's visible, then that would be an indication for treatment. Usually bulky means greater than 10 centimeters. So that's a pretty large lymph node. If your spleen is very large and it's pushing up against your stomach, and again, you have that early satiety, Okay, you become full very easily and it's bothering you. It's affecting your quality of life. Another reason to treat. If you have autoimmune cytopenias. Now what this means, sometimes patients with CLL, their immune system may become a little bit crazy and they can develop what they call autoimmune disorders, like an autoimmune hemolytic anemia or an autoimmune thrombocytopenia. In other words, their white blood cells may make antibodies that may attack your blood cells. And if you have that, it's not as common as you think, but we do see it from time to time. And if you have that, that's another reason to consider treatment. If you have pronounced anemia or pronounced thrombocytopenia, remember that would mean that your CLL stage is higher up. Remember, stage 3 anemia, stage 4 thrombocytopenia. That would be another reason to consider treatment. Now, the important thing here is an elevated white blood cell count only is not an indication for treatment. Think about this. A lot of patients come to see me. Their white blood cell count is very high. As the example I gave you, 50,000. And the patient comes, oh my God, I have leukemia. It's a chronic leukemia. I need treatment. I ask them, how do you feel? I feel well, no lymph nodes, no nothing. I mean, they're pretty much asymptomatic. Guys, you really don't need to be treated. You might not require treatment. So don't panic based on your white blood cell count only. You want to look for something else. And remember, we started off this by saying that there's no evidence that treating you early will prolong your survival. So we treat only if we have to. Okay, so keep that in mind. So what I would ask my doctor, number one, do I need treatment? And if I do need treatment, why? What are the symptoms? What are we treating here, okay? So questions for you to ask. I hope you're still with me. Now we're going to go over the different treatment options. And if you look at this slide, I mean, it makes you nervous because you're like, oh my God, look at all the different treatment options. And that's a good thing. We have a ton of medications that we can use. And we're going to go over some of these, okay? So we have a family of medications called BTK inhibitors like ibrutinib, acalabrutinib, zanubrutinib, pirtobrutinib, all options that we have, okay? Another one is the BCL2 inhibitors like venetoclax. We also have anti-CD20 antibodies like rituximab and obinutuzumab. Also chemotherapy like FCR and BR. We're going to go over this, okay? Also the PI3Ks like duvelisib and idelalisib. We also have lenalidomide, alemtuzumab, chlorambucil, and finally a bone marrow transplant and CAR T therapy. You do not need to memorize this. I'm just showing you this so that you know your doctor has a lot of potential treatment options for you. And what we do, we look at all this and we look at the patient. How strong are you? What's your age? You know, what's the goal here? Do you need treatment? Do you not need treatment? What other illnesses can you have? So for example, maybe you have a history of heart disease. Well, maybe there's some medications here that we'll try to avoid. Or maybe you have really bad diabetes. And, you know, again, we will tailor treatment depending your specific case. And that's the discussion that you have to have with your doctor. Well, let's go over some examples. All right, so a very common